Your immune system is built to switch itself off again. In one long study, the people whose bodies stayed a little switched on had about 70% higher rates of a first major heart event than the people whose bodies did not. 27,000 women followed for 30 years. Not one of them could feel the difference. This episode is 4 questions: what inflammation actually is and why you want it, why it sometimes will not switch off, whether there is any test that tells you how inflamed you are, and what the evidence says actually works, including the parts where the answer is nothing. Chapter 1, what it actually is. Start with the thing almost every video about this gets backwards. Inflammation is not the enemy, it is the defense. It is how your body handles a cut, a splinter, a virus. Take it away entirely, and an ordinary infection becomes the thing that kills you. Doctors have described it the same way for about 2,000 years in 4 words: heat, pain, redness, swelling. Modern textbooks add a 5th. The part stops working properly. That is a sprained ankle. That is a sore throat. You already know exactly what acute inflammation feels like. Here's what is happening under the skin. The blood vessels near the trouble widen and their walls become leaky. More blood arrives, which is the heat and the redness. Fluid seeps out into the tissue, which is the swelling. Before any cell has done anything, the plumbing has already changed. Then the cells. White blood cells stick to the inside of the vessel wall and squeeze out between the cells lining it. Neutrophils go first in enormous numbers. Monocytes follow behind them and turn into macrophages, which are the ones that clean up. And here's the part that matters for everything after this. Acute inflammation is fast and it is short. It starts within minutes to hours. It is usually over within a few days. It is loud. You can feel it, and then it goes. So the real question is not why inflammation happens. It happens because it is supposed to. The question is why, in a lot of people, it starts and then never properly finishes. Chapter 2, why it will not switch off. For a long time, the assumption was that inflammation just runs out. The alarm sounds, the danger passes, the signal fades. That turned out to be wrong. Switching it off is a separate program, and it has to be turned on. 9 independent laboratories signed a definition of it in 2007, and the word they used was active. It even has its own molecules. 4 families of them, with names: lipoxins, resolvins, protectins, and maricines. They do not suppress the alarm, they run the cleanup crew, tell the cells that arrive to stop arriving, and get the debris carried away. Which means chronic inflammation is not inflammation that is too strong. Very often it is inflammation whose off switch never fired. The alarm is quieter than a sprained ankle, it just never stops. That is one of the ways it happens, not the only one. A persistent infection does it. So does a long, low-level irritant, and so do autoimmune conditions. Sometimes there was never an acute phase at all. Anyone who tells you this is one thing with one cause is selling you something. Researchers have a name for the modern version: systemic chronic inflammation. And the comparison to the acute kind is 3 words long: magnitude, high grade against low grade; duration, short-term against persistent and non-resolving; outcome, healing against collateral damage. Low grade is doing a lot of work in that sentence. With a bacterial infection, the standard marker in your blood can run past 500 milligrams per liter. The chronic kind that worries cardiologists sits above 3. That is over 100-fold apart. It is not a smaller version of being ill. It also creeps up on its own. Markers rise with age even in people who stay healthy, and the field named that inflammaging. Nobody has shown that pushing it back down adds years. It is a description, not yet a lever. Here is where it stops being abstract. In your arteries, plaque is not cholesterol quietly stacking up on a wall. Inflammatory cells travel to the damaged part of the artery and release signals. White blood cells arrive, eat the cholesterol, clump together, and that clump is the plaque. The cells that ate the cholesterol are called foam cells, and they do not leave. Over years, the wall thickens into a mound that narrows the channel. Then the same cells release enzymes that weaken the cap, holding the whole thing together. Your immune system builds the plaque and then destabilizes it. Fat tissue is part of this too, and we know because of a measurement from 1997. researchers sampled the blood going into fat tissue and the blood coming out. The inflammatory signal went in at 2.27 and came out at 6.71. The fat was adding it. The idea started a few years earlier in rats. But all of that is a story about mechanism. For years, nobody could say whether inflammation actually causes heart attacks or just turns up alongside them. Then a trial of 10,061 people did the one experiment that settles it. It targeted inflammation directly, and repeat cardiac events went down, hazard ratio 0.85. And it did not lower cholesterol at all. The whole effect came from the inflammation side. It also was not free. Suppressing inflammation that hard-raised fatal infections and deaths from any cause did not fall, which is the clearest possible answer to whether you should go looking for something to suppress yours. Chapter 3, whether you can measure it. The test everyone means is hs-CRP. C-reactive protein is made by your liver when it gets an inflammatory signal, so it is a downstream readout, not the thing itself. The HS part is not a different molecule. It is the same test read further down into the range that used to be called normal. Current guidelines do attach one number to it, 2 milligrams per liter. Above that, it counts as what the guideline calls a risk-enhancing factor. And the table it sits in is headed, in the guideline's own words, if measured. Read what that number is for because it is narrower than it sounds. Its whole job is to help a doctor and one patient whose risk has already been calculated and landed in the middle decide one thing about one treatment. It was never designed to tell you how inflamed you are. And it is not specific to anything. Blood pressure moves it, body weight moves it, smoking moves it, gum disease moves it. The same statement that defined the categories says do not test at all while you have an infection or an injury, because the number will not mean what you think. It gets stranger. If your result comes back above 10, the guideline does not tell your doctor to worry about your heart. It says look for an infection and that the results should be discarded and the test repeated 2 weeks later. The scariest number on the page is the one you are told to throw away. Even a normal result is not one test. The protocol that produced those categories asks for 2 measurements, averaged, ideally 2 weeks apart, in someone who is metabolically stable. Almost nobody who buys a panel gets that. And the reason for that protocol is that the number moves on its own. One study measured 100 stable people repeatedly for a year. 46% crossed the risk line at least once with nothing about them changing. An earlier study was kinder. 2 measurements agreed about 63% of the time, roughly as steady as a cholesterol reading. Both are real. So try a different marker. ESR cannot tell you what is inflamed. Interleukin-6 is unstable unless you freeze it. Fibrinogen did not clear the bar. A white cell count is the most reliable of all of them, reproducible to within 3%, and it is still not endorsed for this, which tells you the problem was never the measurement. Here's the cleanest evidence of where this actually stands. In 2024, the American Heart Association built a brand new cardiovascular risk calculator from scratch. They considered inflammatory markers, they left them out, and said in the paper that these are not routinely recommended for screening. The field says it about itself more bluntly than I would. In a 2019 review in Nature Medicine, 20 researchers wrote that there are presently no standard biomarkers for indicating the presence of health-damaging chronic inflammation. That is the honest answer to the question this episode promised. There is no inflammation score. It is only fair to say the argument is live. In September 2025, the American College of Cardiology called the evidence compelling and clinically actionable and argued this test should be offered far more widely. It is a scientific statement, not a guideline. The guidelines it once changed have not changed. Chapter 4, what actually holds up. Start with the biggest number in this whole area because it is not the one you were expecting. In 2020, the British Medical Journal pooled 121 randomized trials and 21,142 people across 14 popular named diets. No diet significantly improved C-reactive protein at 6 months. one pattern does keep showing up. Across 17 trials and 2,300 people, a Mediterranean pattern was associated with C-reactive protein about 0.98 milligrams per liter lower. But look at the interval. It runs from 1.48 down to 0.49. A real finding and a loose one. Exercise. 83 controlled trials, 3,769 people. Training lowered C-reactive protein with a standardized effect size of 0.26, which by convention is small. It shrank further when people did not lose weight, but it did not disappear. And in one 652-person program, it only moved in the people who started high. And exercise does something that should permanently complicate how you think about this. In 8 marathon runners, an inflammatory signal called interleukin-6 went from about 1.5 before the race to about 94 immediately after. It also raised the body's anti-inflammatory signal more than 20-fold. A spike is not a disease. Weight is where the biggest randomized change shows up. In one 17 to 59 adults with type 2 diabetes, an intensive lifestyle program cut median hs-CRP by 43.6% in a year. Read the control group before you get excited. Theirs fell 16.7% too. Now the one nobody expects. 26 randomized trials, 2,579 people, treating gum disease lowered C-reactive protein in the blood by 0.69 milligrams per liter. That is a bigger measured change than most of the diet evidence from a dentist. And that finding has a history worth knowing. In 2006, the pooled answer to the same question was no significant difference. By 2013, it was 0.37. By 2023, with 26 trials, 0.69. That is not science flip-flopping. That is more trials arriving. And it gets stranger. In a randomized trial in the New England Journal, people had severe gum disease treated intensively, and 24 hours later, their blood vessel function was measurably worse. At 60 days, it had crossed over. At 180 days, the treated group was 2% better. The thing that helps you can look like harm on day one. Sleep is messier than you have been told. 72 studies, more than 50,000 people. Sleep disturbance tracked with higher markers, effect size 0.12, which is small. Long sleep tracked with them too. Short sleep barely did. And when researchers deliberately deprive people of sleep in a laboratory, none of the 3 markers moved. Which brings us to the supplements. A randomized trial put 25,871 people on marine omega-3s or a dummy for 5 years. Major cardiovascular events, hazard ratio 0.92, and the interval crosses 1. The vitamin D arm 0.97. And when the same trial measured inflammatory markers directly in 1,054 of them, the omega-3 arm showed nothing at all. The vitamin D arm did show one thing, markers down 19% at 2 years. That p-value was nominal, meaning uncorrected for testing many things at once. And by year 4, it was gone. If you have seen that 19% quoted somewhere, that is the number, and that is the rest of it. And the anti-inflammatory food lists. Most trace back to a scoring index, built by assigning inflammatory weights to foods and validated by showing that people who score higher tend to test higher. There is no trial where people were assigned to change their score and anyone followed what happened to them. So, inflammation is a defense you cannot live without. The chronic kind is often that defense failing to switch itself off, and it does real damage in artery walls. There is no test that scores it. The things with the best measured evidence are unglamorous, and the popular ones mostly measure out at nothing. The college's own advice to patients, in their words, is 150 minutes of moderate activity a week, a plant-heavy diet, weight loss if it applies to you, and quitting tobacco if you use it. Then they say the thing this channel says. Talk to your own doctor about whether testing makes sense for you. If that was useful, subscribe. Next time, resting heart rate. What that number is actually telling you and whether a lower one is always better. This channel is educational only, it is not medical advice, and the presenter is AI generated. Thanks for watching.